of the particular hypothalamic or cellular mass lesion should be done. Granulomatous infiltrate respond to glucocorticoid administration. In patients with irreversible hypothalamic damage, no treatment can be done. In 30% of patients without without a visible pituitary microadenoma, the condition may resolve spontaneously. Okay. So, then coming to prolactinoma, we'll revise the entire thing once we finish it. Etiology of prolactinoma. Prolactinomas are tumor arising from the lactotrope trail. Account for half of all the functioning pituitary tumors, most common pituitary tumors. With a population evidence of 10 per 1 lakh in men and 30 per 1 lakh in women. Okay, let it be. Mixed tumors that secrete a combination of growth hormone and prolactin, ACTH and prolactin, and rarely TSN and prolactin are also there. So it can secrete just prolactin or GH with prolactin, ACTH with prolactin, or TSH with prolactin. These plurihumoral tumors are usually recognized by immunohistochemistry, sometimes without apparent clinical manifestations. The microadenomas, now this is a definition, microadenomas are less than 1 centimeter in diameter, usually do not invade the paracellular lesion. So microadenomas are less than 1 centimeter and do not invade the paracellular lesion. Macroadenomas are more than 1 centimeter and are locally invasive and impinge on the epithelial structure. The female to male ratio for microadenoma is 20:1, whereas for macroadenoma is 1:1. So micro are very much more common in female, however macro are common in both. The tumor size correlates with the prolactin concentration, right? Value more than 250 are generally associated with macroadenomas. Men tend to present with larger tumors than women because the feature of male hypogonadism are less readily evident. Prolactin levels remain stable in most patients, reflecting the slow growth of this tumor. Okay, so there is slow growth. About 5% of microadenoma progress to long-term macroadenomas. Okay, only 5% progress to macro. Presentation and diagnosis. Women usually present with amenorrhea, fertility, and galactorrhea, which is the triad. If the tumor extends outside the cellar, there will be visual defects. Men presents with impotence, loss of libido, infertility, and signs of CNS compression like headache and visual effect. Impotence, loss of libido, infertility. Assuming physiological and medication induced are excluded, the diagnosis is likely if the prolactin level is more than 200. Less than 100 may be caused by microadenoma and other cellular lesions that decrease the dopamine inhibition and other non-neoplastic causes. For this reason, MRI should be performed in all patients with hyperprolactinemia. It is important to remember that hyperprolactinemia caused secondarily by the mass effect of a non-lactotrope. Even a non-lactotrope lesion may also cause that by compressing the stalk. Consequently, PRL secretion by dopamine agonist does not necessarily indicate the underlying lesion is prolactinoma. So treatment of prolactinoma, because microadenomas rarely progress to macro, no treatment is needed if the patient is asymptomatic and if the fertility is not desired. Okay, the patient need to be monitored by regular serial prolactin measurements and MRI scan. For symptomatic microadenomas, for this was for asymptomatic microadenomas. Okay, first let's check out the next page flowchart, and if then there is anything extra we will mark it. So elevated prolactin level exclude secondary causes and MRI evidence of pituitary mass. If it is a symptomatic prolactinoma, okay, they have not mentioned asymptomatic thing. Okay, I will add it here. If it is asymptomatic micro and fertility not desired, so you will just observe and monitor. What will you monitor? PRL levels and MRI. Okay, whereas if it is a symptomatic prolactinoma, first see whether it is micro or macro. If it is micro, then you give a start with a dopamine agonist and check a serum PRL. If it is decreased to less than 20, then give a maintenance treatment. If it is not responding 20 to 50, then you reassess and increase the dose. If it is more than 50, that means your dopamine thing is not acting, so you consider surgery. Whereas if you give a dopamine agonist and the drug is not tolerant, then you change the dopamine agonist and check for the same thing. or else if it is more than 50, then also you can change the dopamine agonist or go for surgery. Whereas if it is a macroadenoma, this side, macroadenoma may test for visual fields and test for pituitary reserve functions. Okay. Yeah, because it might be compressing other structures also of the pituitary gland. So it may be first you gave a dopamine agonist, whether drug tolerant or not. If drug is not tolerant, then change the dopamine agonist, and after that, on the dopamine agonist, continue and repeat the MRI within 4 months. If within 4 months there is no tumor shrinkage or tumor growth or persistent hyperprolactinemia, then consider surgery. And if there is tumor shrinkage and prolactin is normalized, then monitor prolactin and repeat MRI annual. So basically, I'm trying to say is even in macroadenoma, your first is not to go for surgery direct. First is you will try to control it with a dopamine agonist only after 4 months, and wait for 4 months, mind it. And after 4 months, if it is not responding, only then go for surgery. If it is responding, then you have to continue and maintain prolactin and repeat MRI. Okay. Now let's go back to the theoretical part. Whatever is extra, only that we will mark now. For symptomatic microadenomas, the goal is to control hyperprolactinemia, reduce tumor size, and restoration for, so we have to do everything. Reduce the tumor size, restoration of menses and fertility, and resolution of galactoria. I'm not marking all this. Even this one I'm cancelling the marking because we have mentioned it in the flow chart. Okay. So dopamine agonist should not be titrated to achieve maximum PRL, should be titrated, to achieve the maximum PRL secretion and restoration of reproductive function. The normal PRL does not ensure reduced tumor size. However, tumor shrinkage is not seen in those who do not respond to lower PRL level. For macroadenomas, formal visual field testing should be performed before initiating, isn't it? Visual field testing should be performed before initiating. We saw that an MRI and visual field should be assessed 6 to 12 month interval. MRI as well as visual field until the mass shrinks, and annually thereafter. When the maximum size reduction has occurred, MRI and visual field initially 6 to 12 monthly, and later on once it is reduced to maximum size, that is maximum reduction has occurred, you can do it once yearly. Now treatment, medical treatment. So what are these dopamine agonists that we are going to give?